Social Development at the University of Victoria in British Columbia, Canada. Dr. Pence, thank you very much.
Thank you, Gary. Thank you very much, Gary. And it's a pleasure to welcome you all to the lead panel for this afternoon. As Gary indicated, the focus is views from the ground on investing in young children and their caregivers. And I'm just very pleased that we have this session being offered here, as many of us know that the many innovative activities, effective activities across Africa are taking place all the time. Many have even a substantial history to them, but they're largely invisible, largely not known. And this is an opportunity to highlight at least 3 such programs. I also flagged that a colleague and I have been working over the last year or so on building a compendium of early childhood ECD in Africa. To start, we had less than 100 references we could find. We're now up over 800. And so I'll provide that to the IYCG. So for those individuals that would like to take a closer look at some of the research that has been done, is being done, it includes some of the gray literature as well, but we'll get that posted. But as I was saying, we have this opportunity of bringing to light visibility several presentations today. Our lead speaker, Freelam Shababa, is director of the Ethiopia School Meal Initiative. Our second speaker is Dr. Jeffrey Admedes. He's a senior social demographer at the International Center for Research on Women. He will be followed by Dr. Menelik Desta Arga, who is the executive director of the School Readiness Initiative, a non-governmental charity organization that works in collaboration with Addis Ababa Education Bureau to promote a child-friendly preschool program. And then there will be a research reaction response from Dr. Lorraine Scherer. She is a consultant clinical psychologist and professor of clinical and health psychology at University College London Medical School. She is head of the health psychology unit. She is editor of the International Journal AIDS Care, as well as Psychology, Health and Medicine, and Vulnerable Children and Youth Studies. So, Freelam Shababa, if you'd start us off, thank you very much.
My name is Frey, founding director of the Ethiopia School Meal Initiative, a local nonprofit organization that's established to design and implement sustainable school meal programs in Ethiopian communities. When I saw the word investing, I always like to understand words and their meanings, and investment is time, energy, or matter spent in the hope of future benefits actualized with a specified date or time frame. So when we say investing in children, time, energy, resource spent, hoping of future benefits that will be realized through the children. So the question was, do we really realize that? So I just want to tell you the story of a little kid that brought me into establishing the Ethiopia School Meal Initiative. My background is development, but I was running a private school that I founded for 10 years. It was from K to 12 private school, a very large private school that I was leading. During this time, a little kid who was bringing an empty lunchbox to this school, that experience brought me into thinking, what is it that we have to do in order to secure children? Having schools alone is not enough. So I started to ask a question. This little bright kid who used to be a top student in the classroom started to decline on the 3rd year, and the teachers found out he was bringing an empty lunchbox to an all-day school. So this was my turning point, asking a lot of questions, saying, who is responsible for this? What is it that we did not do? What is it that we have to do? How many children are affected by this problem? So these are the facts in Ethiopia. We have still very large number of stunting children, 40%, an average 18% dropout at a country level, and still very high repetition rate. So the critical issues on child investment, we feel, do our values influence the kind of knowledge we're seeking, the kind of policies we want to design, the systems, programs, and even finance are these all related to our values? What do we value? So our approach was trying to understand our philosophy of a good life. What is a good life in our communities? How do we value children? Do we really understand when we say children, born and unborn? What is our knowledge on food? What is our philosophy of schools? What kind of schools do we need? Why do we need schools at all? Can we make our schools contextual? Are they contextual? Do they really answer our questions? What is our dream on good communities? Can economic growth alone address all social problems? And questions, a lot of questions we came up with. So after asking all these, our findings were there was a great need for intact social systems. So we say the school meal as a means to address malnutrition. So our approach was, the challenge is Ethiopia is not financially ready to feed all its children since we have 18,000 primary schools and we have 40% of them stunted. The challenge is, we're not ready financially to feed all our children. So the question was, how can we design an Ethiopian school meal program that is sustainable and affordable? So we designed a meal framework we call it SSM, that the Ethiopia school meal model has to be simple, meaning it should not have a very complex process. It should be understood by the local people. Sustainable meaning it has to be affordable. It has to be something that can generate income so it can run by itself. Manageable meaning it should be managed by the local people without requiring an external expertise. So when we talked about these things, the first thing that came into my mind is what kind of food, what kind of nutrition. So we thought about milk. Milk has a lot of nutrients. I don't have to lecture you about that, but based on our survey, only less than 1% of students know the taste of milk. They don't have access to milk, based on our surveys. So milk is a very expensive drink in our communities. But to purchase a cup of milk for a student, and we have a large number of students in our schools, we said, instead of buying the milk, why don't we take the cows to the children? Why don't we buy the cows and take the cows to schools? We had to experiment that. This is the barn we built in the first school to do our experiment. We took only 2 cows because we had to be careful about decision. We didn't know how the cows would affect the school environment. We didn't know, so we had to do an action research. We took the cows, we had dialogues with the school community, we had dialogues with the children. So we did our experiment. It turned out that it actually works well since our community likes cows so much. We didn't know until we took the cows to the school community. So we took the cows and we decided instead of 2 cows, 10 cows per school. The amount of milk produced from 10 cows will actually serve 500 school children every day during school days because they can produce more than 100 liters of milk every day. So the standard was 200 ml per day for a child. And then we designed it to be self-sustained so the school can sell half of the milk to communities and then run their own administrative cost. So 10 cows per school, we built local kitchens and they bake bread every day. The bread was baked from the income generated from the school, the milk sale. So the school does not need any support to provide the bread. They could do that by selling half of the milk. This is cow feed. They can afford to purchase cow feed for the cows. We experimented this in different cities of the country. This is Sabata. Some of the group visited this dairy farm Saturday morning. Bahardar and Sakota is the area where If you remember that Ethiopia was on a global report for drought, and many people died in that area due to starvation. This is the area where we experimented the school dairy farm also working very well, children drinking milk every day. We established a school milk forum to engage school communities about the importance of milk so that they can support each other. So we create awareness and build the capacity of schools. So the benefits were instant. When the children started drinking milk, the instant benefits were that the school attendance was almost 100% instantly when we started providing milk. Enrollment increased. School capacity was increased, so we saw that the school had a capacity to provide milk for all the children who were coming to the schools, which we thought that was very important, making schools contextual. When I said it earlier, if we have children who are coming to school without having breakfast, I think breakfast should be served in the schools. We argued with our Ministry of Education, we have to define education for our children. What is education if children are coming to school without having breakfast? I think class should be closed until breakfast is ready for the children. Otherwise, there is no meaning to our education. So we try to bring this important issue of nutrition on the top of our education agenda, nutrition before education. Well, it's connected. We can't separate these two. It created wealth for the schools, so capacitating the schools. We see the need for capacitating the schools to provide meals for their students in a way that's sustainable and engaging the whole community. Created jobs for a school community. People work in the dairy farm, are parents of the children. So it's technically bringing communities to schools, changing schools into a community solution center, using the dairy farms as a training center for the local farmers, having this dialogue with mothers, pregnant mothers. Someone was suggesting yesterday, in fact it was Larry suggesting yesterday, how we were planning to engage pregnant mothers coming to schools to get fresh milk, which is possible. We see the future in this school dairy farm. So dairy management knowledge, as you might know, our country focus has been mainly on crop, 5 minutes, okay, mainly on crop production, but not on dairy. So dairy is, I think, for most developed countries, dairy has been a foundation for their even economic growth. So we see the future in this school dairy. Multiplies itself. The cows give birth every year. So the summary is we spend $57,000 US for one school, one-time investment only. You don't have to support the school after that. They can support other schools, huge capacity. So community value systems and level of knowledge need great attention in terms of child investment. Therefore, the first investment should involve communities to make the change long-lasting. I think we need to understand what's important to communities in order to make them invest in children. Thank you very much.
Well, thank you, and I hope you're all awake and feeling full and satisfied after lunch, especially following a presentation on meals. I'm here to present today on the Towards Improved Economic and Sexual Reproductive Health Outcomes for Adolescent Girls, which is a mouthful of a name for a project, which is more commonly referred to as the TESFA project. And TESFA in Amharic means hope. This project was focused on working with married adolescent girls. And why focus on married adolescent girls? Well, we know that estimates are that there'll be 140 million more of these girls, married girls, over the next 10 years. We know that there's already over 700 million people living in this world who were married as girls. So this is a large and important group of people. They're also the primary caregivers for many of the young children that we're interested in many ways. So how does child marriage affect, what is the effect of child marriage, and what can we expect? Why would we want to work with married girls? Well, we know that for girls themselves, marrying early often means the end of their education. It means the beginning of sexual activity and childbearing, often at very young ages, the introduction of a whole new range of health issues and concerns that they need to think about, and in many cases, a significant loss of autonomy, and ability to choose for themselves. For their children, the children of women who have married very early are much more susceptible to a range of poor health outcomes, are more likely to live in poor households, and suffer a number of issues that are related to development as we're looking at it now. Is this working for me? Yes. So the TESFA program operated in 2 rural wards in the Amhara region of Ethiopia, targeting 5,000 ever-married girls aged 14 to 19. And ever-married in this context means both people who are currently married and those who were formerly married. And Amhara region of Ethiopia has historically had some of the highest rates of child marriage in the world. It has changed quite significantly over the last 10 or 15 years, but it also has quite high rates of divorce. And so there are a lot of girls out there who are still young, maybe with children, who are in limbo in terms of marital status. And I can see that some of my text is slipping off the side of the screen there, but don't worry about it, it's not important. The program itself focused on delivering 3 types of content to these girls. The first was an economic empowerment program, really focused on income-generating activities and other training related to economic empowerment. The second was much more around sexual and reproductive health. And the third was a combination of the 2. And I'll get onto why that matters and why that particular structure was selected before. So the project itself was implemented using a quite innovative group-based peer education model, building off CARE Ethiopia, as well CARE in general, CARE Global's VSLA, Village Saving and Loan Association model, which is group-based. So groups are largely autonomous within themselves, and they set up their own structures, but they receive training through this group system. So the groups themselves nominate 2 facilitators who receive an additional week of training, and then they would come back, and they are in charge of passing on the key knowledge of the program with assistance from some staff, but really not very heavy engagement once the training is done. The program also really benefited from key engagement with communities that we were working in. So the communities were asked to nominate a group of people who could act as representatives of the community for the project. And the structure of those groups was set by CARE to make sure that it was representative of all groups in the community. But then this group became a liaison for the project with the community and with the girls, and supporting the girls' groups that were operating in their communities. And they received a curriculum as well. So they also were being trained on a variety of issues, including empowerment, the beneficial effects of delayed marriage, and so forth. And the idea of these groups is that they're self-critical. They're looking at their communities, they're looking at the issues within their own communities, and coming up with ideas on how to solve them. And this turned out to be really critical. The building of community support turned out, these groups ended up being key agents of change all on their own without that necessarily being the goal of the first project. So the curriculum was also tailored, obviously, building off models that had worked primarily with adults to be much more suited to the needs of adolescent girls themselves, but in the context of marriage. So a lot of it was focused on negotiation skills, working with their family and with their husbands around different aspects of the program. So I'll move quickly through some of the more technical pieces, but the main goal of the evaluation was to try to understand that if you do put these 2 pieces in combination, does that result in some synergistic relationship where both are improved? So the idea would be that a girl who's receiving economic empowerment training will be more empowered economically, maybe will have more resources to access sexual and reproductive health facilities and services. When accessing those services, she may then feel that she can invest more in her future and have more confidence in her future. So the idea was that there was the potential for some virtuous circle that could be developed there. We used a quasi-experimental design, so there was a comparison group, and we compared the same outcomes across all of the arms so that we could evaluate them both against each other and against the comparison group. So we have an estimate of total effect and of relative effect. The data that we used were primarily quantitative, so baseline, end line. The program was a year long, so we collected immediately before the beginning of the program and afterwards. Just over 3,000 girls were interviewed at both baseline and end line. We did also collect qualitative data, focus group discussions, in-depth discussions with community members and girls who participated, and used an innovative photo voice data collection system where girls were given cameras, sent out into their community with instructions to take pictures of things that illustrated the effect of the program on their lives. And we got back just amazing pictures of men engaging in childcare, men cooking, men doing different things, or their savings or their income generating activities, the animals that they had purchased and so forth. It was really quite a powerful tool for allowing the voice of the girls to come through in a way that even the qualitative research did not. And of course we collected monitoring data throughout the life of the project. So what did we see? Well, it's a little probably not very clear for you all at the back there, but what we saw was real sharp increases in economic activity across the board, including in the comparison area, probably as a result of the really rapid economic change that was going on in Ethiopia at that point. And as you probably all know by now, Ethiopia is one of the world's fastest growing economies, certainly in the region. And this was certainly evident out here, even in these rural areas. There was really sharp increases in infrastructure, shifts in road quality, in cell coverage, access to a large number of different resources. So things had really changed. But nonetheless, what you see is that if you look at these lines here, the one on the very far left is the economic empowerment, the middle one is the sexual reproductive health arm, and the third one over is the combined arm, and the last one is your control group. And so in this case, what's presented here is the proportions of girls who responded that, yes, they would be able to feed their family on their own in a crisis for 2 weeks. And as you can see, there were very significant gains, but particularly in the intervention arms, and in the combined arm in particular. But if you look at savings, which is another way of thinking about this issue and it was a real focus of the economic intervention, you can see that all three of the arms, on the left, you could just focus on the slope of these lines. All three of the intervention arms saw really dramatic increases in the proportions of girls reporting that they had savings of their own. In the two arms that included the economic component, that's not particularly surprising because that was the intervention, but the SRH arm also saw that. And part of the reason for that is purely contextual. There are traditional saving mechanisms in this area that typically work within groups. So the girls, by coming together in groups, spontaneously started saving together. But the key differences between the intervention arms really came out when we asked them about what they were using those savings for, what they planned to use the saving for. And what we saw there was when we looked at girls who were saving for productive investment, for thinking about things of the future. So it was either investing in their education, so human capital development, or actual capital, buying inputs for agriculture, investing in their own income generating activities. We saw real sharp increases only in the two arms that included the economic training. What we saw in the SRH arm, yes, increases in the proportion with savings, but virtually no increases at all in terms of what they were saving for, needing to you save for a productive purpose. So much more of that was for consumer expenditure and so forth. So moving quickly to the SRH outcomes, and no, there we go. What we saw was very large changes in knowledge. So it's not too surprising, moving knowledge isn't as challenging as moving behavior. What we saw was really dramatic increases in the percentages of girls saying that they knew a way to avoid sexually transmitted diseases. We saw improvements in the percentage that reported being able to use a condom effectively. Increases in correct knowledge of antenatal care requirements. So these really just dramatic improvements across the board. And this was particularly in the SRH arm and in the combined arm. The control group saw improvements over the same period, but they were much smaller And that difference is statistically significant. You can't see the very edge of it. But overall, I think there's very strong evidence that there was quite dramatic change for sexual and reproductive health as a result of this program. And again, here we're talking about young married women. So when we look at behavior, which is always the tough one to shift, we also saw some real changes there as well. And in this case here on the left, we have current use of modern contraceptive methods, and you can see that slope of the line again is significantly greater for the two middle groups, which is the SRH and combined arms. And then having visited a clinic in the past 6 months to obtain contraception, again, you see this really quite significantly larger increase for those two arms than either in the arm just receiving economic training or the arm with nothing, or it was a delayed implementation actually. So these are just two examples of some of the changes that we saw, and they really were quite large. And so the changes were very dramatic. And what we realized, and what the girls themselves were telling us, is that nobody was working with them at all. They had largely fallen through the cracks in the health system. And this is an area where 90% of births take place at home. So they're not in the health system, they're not in school, they're largely invisible. They're also not visible particularly in their community because they have real restrictions on mobility. And so just working with them in any way was creating an impetus of change that was also supported by the community effects. Now thinking intergenerationally, this is correctly reporting the number of recommended antenatal visits, as I said, had really increased in terms of knowledge. There was a little, not as strong an effect in terms of behavior, probably reflecting issues around access. But there was real changes in intentions to give birth at a health center. There's real shifts in other aspects that I think have important intergenerational effects, such as like feelings of satisfaction in relationship, better communication with their partner, better communication with their families. So there are these real positive issues positive changes in critical issues for family life, broadly speaking. So overall, I think there's strong evidence of a beneficial effect of participation in the program in one sense or another. It was particularly clear for the SRH outcomes. The economic outcomes were clouded by the broader macro changes that were going on. There was very important and significant support for this in the community that developed that really facilitated the work of the project and built the support base for the girls. In terms of the combined program, we didn't see much evidence of this magic synergy. But what we did see is that while the effect for the combined arm tended to be smaller than the other arm, than the topic-specific arms, there was more, the number of outcomes that were influenced in that arm were significantly larger. So those in the SRH arm did see greater SRH outcomes or greater improvement in the SRH outcomes than those in the combined arm, but they didn't see the equivalent in the economic arm. And so when looking at these broader range of outcomes, the combined arm certainly did better. So I think that in thinking through how we can better work with caregivers and children for this type of population, which is quite large in Ethiopia, we need to think very carefully about what types of programming we want and what exactly we're hoping to achieve. Thank you.
My name is Menelik. I run a school readiness program with Addis Ababa Education Bureau. This is an organization that has been running for the last 5 years formally. This organization, School Readiness Initiative, has been running since 2007 informally. We started this program in 2006. Actually, while discussing, I was doing my postdoc, and there were other Ethiopian colleagues doing developmental neurology, psychology, and pediatrics, and we were sitting in New York discussing Ethiopia's problem. And suddenly, a guy by the name Irving Fish, who is a professor of pediatric neurology at New York University, who has been head of that department until he retired a few years back. He challenged everybody, now you guys, why don't you do something to benefit Ethiopia? And this is how we started this program. Then we started discussing amongst ourselves what's Ethiopia's problem, and the literature and everything that was about Ethiopia's problems came down to education. And one particular report of World Bank 2005 just hooked us with this idea of working on education. And in that report, it said that if you could educate Ethiopians to grade 4 level, you could reduce the poverty index by 18%. This was very, very interesting for all of us. And then we came back to Ethiopia, and then we went to the Ministry of Education, and we fished for data. And we found, more, for us then, who were ignorant of what was happening in our own country. We found shocking evidence that, in the first place, less than 5% of children get enrolled. And then, out of those enrolled, 65% of them do not go beyond elementary grades. We never thought that was the case because we were successful in our own way. We thought everybody was successful. And then we went back doing literature search, and then we found out that, and there were lots of information at the time, that lack of success in the school, reasons for dropout rates were mainly because of lack of early preparation. And then we started working on that since 2007, and we piloted a couple of places. Initially, when we went to the Ministry of Education, things were very difficult because, like we all know, in most countries, preschool program is not government-funded project, the same as here, still is. And then we had an idea, and that idea was to pilot and show it. We found out that most education officials, they thought this was very difficult, this was impossible. And then we decided to do, why not we try it and show them. And then I translated one of the Head Start programs from the United States, which I later gave to education professionals here as a teachers training college. They did a very good job and adapted it to the local situation. And my colleague, Tasfai Getana, who is now a big shot at George Washington, who was then a resident of Irving Fish at New York University, he translated the Peabody Developmental Assessment, and that was again validated to the Ethiopian context. And then we did those pilot for a year, and after a year, we went with those results to the Ministry of Education, and I saw the name of our Deputy Minister Fuad. He was very happy with that, and he recommended his subordinates to look into those programs. But the best thing that happened to us was that the Addis Ababa Government Education Bureau heard about our presentation, and they called me. They said, "Come, please present to us." And I presented there, and from that time on, we've been working together. And against the national policy, which does not support the treasury to fund preschool education, Addis Ababa government went out of the box, and up to now, they are putting in money. We started with 10 schools, the government to provide the school premises, teacher salaries, and everything. And our duty was to empower the teachers, to empower parents, to improve quality. And the government liked what was going on over the subsequent years. And they have now reached 197 government-run preschools in the city alone, mostly for children from families who cannot afford to send their children to the expensive private schools. And our vision was, we wanted every child to stay in school, and not only to stay in school, but also to succeed in a holistic manner. We started with 80 children. Now we have over 10,000 children, and we are in 52 schools who are employing 436, paid by the government. And our program is, like I said, we have a holistic approach. And those were very much like, then 2 years ago, we were awarded by the minister alongside UNICEF and USAID for our improvement for our contribution to quality. Beyond that, more than the award and the trophy that I received, what I like most is that the government owned everything. It's now, I'm not going, from school to please apply. The government has issued decree as a city government that every preschool has to apply this curriculum. Every preschool has to use these guidelines. And they have their own monitoring and evaluation mechanisms, which we also help with. And recently, we were lucky to be supported from the government of Canada to run a school mental health program. And now I'm not talking about the other things. I'm going to tell you about our school mental health program. The school mental health program is something very innovative for Ethiopia. In the first place, mental health problems are attributed, culturally to preternatural factors, and almost 90% of the times, anybody with behavior or mental problem will not be going to the medical alternative, but elsewhere, traditionally. And even if people are aware of the medical contributions benefit, the system is unable to provide services because there is a very much scarcity of professionals in the field of mental health, particularly when it comes to childhood mental problems. There is almost no service in the country. So our rationale was that in such situations, the schools should be the best place to efficiently start addressing the issue of behavior or mental health problems in our children. And we were lucky to be supported by Grand Challenges Canada. The CEO of Grand Challenges Canada, Dr. Peter Singh, was here last week. He visited some of our sites. He spent Saturday visiting sites, and he was impressed, and he has released it on his Twitter. And I was very happy for what he commented on. Now, the objectives of the project is, like I said, we want to improve quality, and like is known, it's teachers and parents, it's the primary leaders in child development, early child development particularly. So we started in the first 32 schools to implement the mental health project to empower teachers and parents, and we had various activities with particular milestones. This is how we developed our model. We had inputs, we started with having everything in place before we embarked on. The one best thing about this supporter, Grand Challenges Canada, doesn't only just give you money. They help you to do your job effectively. So we did, different level programs, and we were successful in all of them. And after implementing the empowering activities, we now remain with assessments. And luckily, we are associated with various institutions with capable brains, and we are working on 6 data sets now. At community level, at school level, and at health facility level. And we have different variables to study, and we did all scientific procedures to do. And the measurements we did to assess our intervention is that we study magnitude of mental illness, both in adults and children. We do assess public well-being, community well-being, and also the public's attitude towards the mentally ill people. We study also, one of the things that impinges on child behavior is the way we discipline our children, particularly in the development aspect of behavior. So we study methods of child disciplining in our community. And to see if our teacher training has benefited, we do CAP studies. And we also do another assessment of the teachers at the school level. We want to see if our trainings has helped them identify signs and symptoms of mental illness. And we are doing those things also. We also assess, where everybody diagnosed by the teachers referred to our centers, and the centers, we have professionals who assess those, and they are started on treatment. So we also assess the changes in their functionality also on symptom reduction. And to help the institutions that collaborate with us, the hospitals, we try to help them by studying if their services are attractive to patients. And we also assess individual patients' perception about what others feel about them. And our results show that in adults, we found 16.2% depression. This is in the public. And in children, we found 19.3% prevalence of any mental health disorder. And interestingly, we found that prosocial behavior was observed only in 3% of the population. This was very much concerning for us. It means that we have a lot to do in helping our children develop with prosocial behavior. And we also have got, this was very interesting again. Most people felt very okay, despite living, in difficult situations, as this community is. We are working in the poorest of poor Ethiopian communities. And we found out that only 15.9% feel that they don't feel well, overall well-being. And public stigma, again, was minimal, and it was only 12% who feel bad. The child disciplining method is another area where we found that there is a lot to do with regard to changing attitudes in the community. Like we see here, almost more than three quarters of the population is still physical aggressive. They use physical aggressive means to discipline children. And change in knowledge, attitude, and practice, we did the first arm, and it's horribly poor, but gradually it changed, better and better, and now there is not much difference between pre and post assessments. The teacher's skill of diagnosing children with mental illness, again, this was very poor initially, and we are going to do the next one. And client satisfaction, another very encouraging thing what we found in the institutions where we work. This is a bit of a problem to conclude that this is very good, because we've been working with this hospital for 7 years. Myself was heading the Child and Health Behavior Unit, and we always presented in the pediatric department, in the burn unit, and in the gyne ops. So people have been already worked on. So although the client satisfaction is very good, I'm not sure if this can help us, speak for the general public. And the perceived stigma in the patients, again, the same thing. So what we remain up with is we have now all that requires for early childhood development. Finally, I want to tell you what we did. We developed what we think is good, but we didn't stop there. We asked the education ministry to invite, up to 2010, everything that has to do with, I'm told to stop, but I just want to tell you this for a minute. Everything was on the education ministry to do with children, especially early child education. But the policy gives the mandate to 3 ministries in Ethiopia: Ministry of Health, Ministry of Education, and Ministry of Women's and Children's Affairs. So what we found out was that mostly, low-level workers in those ministries think that this is very difficult. So after producing everything that's required, we invited everybody together, and then they discussed, they evaluated repeatedly, and then they agreed everything. So now we have 11 manuals of early child care and education, recommended and adopted by all 3 partner ministries, and we are ready to scale up those. Thank you.
Good afternoon. Who's awake? Larry's awake, so I'll carry on. Well, weren't those absolutely fascinating? And you know, 10 years ago, we'd come to a discussion and we wouldn't have the quality, the range, the quantity, and the depth, which makes my job very easy. I'm asked to do some research reflections, which is fun to try and do, where you have a minute or a millisecond between Menelik sitting down and me standing up. But I'm a woman, so I can multitask. So here we have some reflections. First of all, I think you can see there's a theme of integration. We started yesterday by even the Institute of Medicine's become integrated, and it's now the National, I forget, NAM. And what does this tell us? It tells us that we are in an era of integration. You saw very clearly in those 3 studies the idea of integrating at very many levels. It allows us with complexity. It looks at the intersections. It brings in multiple disciplines, multiple concepts, and multiple visions. And I thought that was so nicely articulated in Jeff's talk, in Menelik's talk. You really saw how do we deal with complexity. I think the days of silos are probably over. Now, in terms of research, and the research imperative is very strong here, I think you need to think a little bit about where do we move? Where do we start? How do we get this process going? Do we start with theory and move to action, which is a lot of what we've been talking about, or do we take the kinds of examples that we saw here? We start with action and we move to theory. And I loved it. We even have a theory emerging. You know, before we had, if you looked at the Millennium Development Goals, it was very much survival. Children, what did you see out of those goals? They should survive. It's a great idea, but it's not enough. And you even saw in Frielem's proposition of a theory, it was a good life. Now that's a new theory. That's thrival, isn't it? And that's what you'll see in the SDGs. What about evidence? Well, for many decades, programming for children was what I call a knee-jerk. The knee-jerk was children need stuff, let's give it to them. And it was ill thought through, and it wasn't evaluated. And it meant we had some good programs, but we also possibly had some poor ones. We didn't know where we were going. We didn't know how to do it. And here you have 3 examples of good programs. And you see this balance of investing both in children and investing in programs. So we see a lot of progress. Proof of concept. Well, we know that education works. We know that nutrition works. We know that family support works. We know that early childhood development works. Stimulation works. Good health works. And here we have some examples of some new programs where things seem to be working. And what can we take out of all of them and draw from what they did? Well, we actually see a process of setting up, and it seems to be doable, articulated, and it's really very possible. There are drivers that start us to act, and they were very clear in all of these. There's a process, and if you don't go through the process, if you jump from driver to action, you will miss the process, and the careful thinking and planning, you could see the benefits. Then you need feedback loops, and if you don't have them, and you're just in the early stages, you need to get them and get them quickly. And then you see, almost inevitable, both these programs and the ones described in the previous session, you have this growth and diversification. And that's really when you feel you're moving, you feel you're onto something, and that's really an indicator of scale. But scale is also about ownership as well as scale. Whose program is it? Who does it? Who delivers it? To whom does it belong? So I'll just briefly give you a quick run-through of the Ethiopia School Meal Initiative, which was really good. I mean, they saw stunted children. You have to do something. They fed them milk and bread. This is not rocket science. This is not getting to the moon. They've only been up for a year. Why didn't it occur to somebody? I mean, it's unbelievable that it took an inspirational individual to say, stop. But what she did say was, in terms of growth, the children would grow, that was the problem, but also they were more alert. So the psychologist in me says, we can measure this. Now here is a project ripe for evaluation, ripe for design. It's got community engagement, it's got secondary benefits, skills and agency. The International Centre for Research on Women, well, you don't have to shout out loud to governments. They respond very well to these few lines. You don't even have to label them. We can all see the slope. And evidence speaks, and it speaks loudly. Walk in with a megaphone. You won't get as far these days as if you walk in with a graph. So if you want traction, this is the kind of data we need. I was a bit cheeky with Menelik's data, because the thing that occurred to me was, when you have this vast baseline data, it not only describes your problem, which he did very eloquently, but it allows you to start asking questions. Look, I just plotted for you the depression versus no depression on his figures, the harsh punishment versus no harsh punishment on his figures, and in fact the depression looked very similar in its visual to the mental health, the common mental health problems. So now we can ask the question, were they the same children? Was there comorbidity? Who were those 19 or 20-something%? Were they different children? Is everyone going to have some problem but a different one? Or does a core of children have multiple problems and some children? And how do we deal differently? So gathering the evaluation not only gives you the feedback, it allows you to ask much more complex questions. So evaluation provides opportunities as well as imperatives. The opportunity to ask, the imperative to move on and to start designing around. Yesterday we saw a lovely idea of how do you start change. The idea, and I can't remember, it was a senator, was it Larry's slide or was it Teresa? Somebody came up with this great slide of knowledge, policy, but political will. And I think from today's presentations we see that theory is missing something, community will. I think you have to add into that community will. And if you just have knowledge, policy, and political will, you're leaving out the big players, the community. So I have a plea. And the plea was, when I looked at it, there's a funny acronym there. It says OBMR, or a PAR. You know, early childhood is about good quality. And everyone has got acronyms. I hate acronyms. The TESFA, I don't know what TESFA is. I love your program. I don't like your acronym. So I'm going to fall foul of my own advice. OBMR is sort of Obama. Would anyone remember that word? Thank you.
A great series of presentations, great reflection. I want to applaud again this panel for their great contributions, idea generation, and staying within the 15 minutes on each one of these. You all did a great job. Thank you. Okay, we have a good amount of time for questions. We can start off, I think, with 4, and then see what our timing is looking like after that. So I have difficulty seeing down this side here because of this bright light. But I see a hand in the middle and to the right and then right in front. So there's 3 here. Is there a 4th question we have? Okay, let's start off with those 3 questions. Please, the man with the blue shirt.
Thank you. My name is Tolan Makongo. I'm coming from Swaziland. My question is directed to Jeffrey. I was presented for the TESFA program. I want to know what is the model that was used for the girls, and girls being young people. That's another question. Most of the time, they wouldn't be interested in savings things. They would be interested in other things. So how did you get the interest from them, just to put them into the program. Thank you.
Thank you.
The question is for Furlam. It was very interesting to be at the site and see the school. One question which we touched on, are there any plans, or if not, what are the barriers to expand the milk and the bread to other crops and vegetables from nutrition point of view? Was this looked at? And the other question, which I think we touched on during the trip, the visit, was the fortification of the additional fortification. And thirdly, is there a spillover to families where the children who are at risk of stunting that are not yet in school, do you see spillover and those families being able to introduce these kind of foods to prevent stunting?
Thank you. Thank you. I would like to know from Jeffrey, if the girls were connected to services, were there diverse, different methods for family planning, and did they have to pay for those services? And also from Menelik, I know that you mentioned that the teachers were trained to identify the children with mental health. How was then the connection to, I know that they went to the hospital is providing the services, but how is that linked? Do someone take the children to the hospital, the frequency, and perhaps the intensity of the interventions? Thank you.
Thank you for those questions. So let me start with the question about what the model was. So as I said in the presentation, it was a group-based peer education approach. So the girls were formed into groups. Recruitment was conducted through the community. So Care Ethiopia, who was the prime implementer of the program, first went into the community 2 or 3 months before we began working there, and worked with community leaders to try to identify eligible girls. And then they talked to their families to try to get permission for the girls to go. And despite our best efforts to try to communicate directly with girls, many of the girls who came because their family told them to. So it's just a reality of life in that community that it's very difficult to reach girls directly with recruitment efforts. So in terms of the recruitment model, it was very community-based, but it was had some challenges. The implementation model had them meeting every 2 weeks. So they met basically a total of over a course of a year, about 25 times. And they met together, and they would, in the savings model, they would bring savings. They had a rule for the first 6 months of only saving, and then they would lend within the group. In terms of the SRH was similar, but it didn't have the same sort of scale-up period for saving because they were just learning. So the community facilitators who had received the training would go and they would train their peers, which is quite remarkable. This is a very conservative area, so they were having to talk about human anatomy and the reproductive system, using words which are basically taboo in these communities. But I think that the takeaway, and this relates to the other piece of your question, is that these girls were very appreciative of anyone paying any attention to them. They're not really the target of any interventions. They're not really the target of government programs because they're already married, so child marriage prevention programs don't target them. They're out of school, so school-based programs don't target them. They're not really using the health system yet because even if they're starting childbearing, they're doing that largely outside of the health system, so they're not really being targeted either. So the thing is, one girl told me that this is the first time anyone has done anything for me. And I think the issue is, I really did feel that they were very interested in saving. They were very interested in having money of their own, but it never was an option before. And so it was not, motivation of the girls was never an issue. The girls are incredibly motivated, they just need the opportunities. In terms of connecting them to services, it was a plan of ours to connect them to services, but it never really happened the way as we planned it. So this largely was not a formal connection to services. They do have access to health clinics. There was a connection through the health extension worker the health extension worker was included in the community groups. But those of you who have ever worked with the health extension workers here know that they're just incredibly overburdened. It's a remarkable program, but it is one that's being overused by everyone, including us in this program. So in order to access services, girls had to go to health clinics themselves. And there, the services are free, but to get there is not necessarily easy for these girls. I mean, some of these girls would walk 2 hours to a meeting, and they would be walking at least 2 hours to the nearest health center. So access remains an issue. In terms of the diversity of services, it's very limited. So they can go there and they can access what's available. And typically that's injectables or hormonal long-term acting stuff. That's very little actual choice in that.
Thank you. Any plans to expand the school dairy farm? Yes. I don't know if you have the information, but the Ethiopian government declared last week zero child undernutrition by the year 2030. It's called Sakota Declaration. Under this declaration, there will be huge steps taken from government, local practitioners, and international partners also. So we have been proposing to different states to expand the dairy farm, and they are considering it to expand. So yes, we will see that. Variety of foods, that's the next step. I think we felt like we had to start somewhere and then gradually grow into that, while in the meantime community is learning how to do this, because that's very important. So we will definitely have variety of foods in the years to come, but we don't know how long it will take the communities to grasp on the important skills. Managing food is a very difficult thing by nature, so we don't want to go too fast on them. We want them to be comfortable so that the school community decides, this is what we want to do for our children, this is what we want to give them. We want them to have lunch, we want them to have snacks. We want them to decide that instead of us imposing. Fortification, yes, this is all the process that we have to go through, but it's in the plan. Children that are not yet born, that are not yet in schools, yes. We're thinking social innovation is extremely important to do this. When I say that, we're asking how do we transform our schools into thinking even the unborn children are their future students, so that it'll be easier in the classroom, less work in the classroom if the mothers drink milk now. How do we make them into thinking towards that? How do we make the school principal thinking about the unborn children? After 3 years, they will be my students, so I should go visit to their house and make sure the mother is drinking milk, because it will be less work for me in the classroom. If we do that, then I think we have a community that cares for everyone, born, unborn. So we plan to work with communities and make sure that they have this knowledge, and it's something that we all can do if we understand how important it is. So yes, we plan to do that too.
Thank you. Thank you for that question. You asked whether there was a link between the schools and the health service providers. Yes, there is a link. There are 3 ways how we approach that. We have our social workers who are responsible for a number of schools. These social workers, they meet teachers and parents and anybody who's identified as having any behavior problem. They will provide them with pre-prepared cards to take to the hospitals with which we have agreements. We have 2 government hospitals who are expected to give free service for anybody going there with a school readiness card. So the link is there. Secondly, we are not only empowering teachers, we are also empowering parents. So the parents themselves are also getting more and more acquainted with the health service providers, and they themselves take also their children out. So yes, there is a link.
Any other questions? There's 1, 2. Can you take the 2 more questions, please?
Thank you very much. My name is Abaram Makonnen. I'm from Save the Children. Save the Children as a child organization is very much interested on all the initiatives that's presented here. I want to touch one point raised by Dr. Mendlake, that is on child disciplining. This is a very big topic. Without making any sweeping generalization, in our culture, we have constraints, we have beliefs that a child knows nothing, basically. In Amharic, there is a saying, "Lijbuniakal." I'm sorry, most of you don't know what I said, but it means literally, a child knows nothing. So with this basis, the parents think that punishing the child makes the child disciplined. In fact, on the contrary, it doesn't, because the child is curious, a child wants to know, a child is developing every day. He or she needs to be given a chance to find out, to discover the world. We don't. In general, in Ethiopia, we don't give them that chance. And this cultural impediment really affects anything we do in terms of preschool or generally looking after the child. So my fear is when we talk about investing on the child, we need to talk about investing on changing the mindset, that age-old, culturally ingrained belief and practices that really hinder a child's development. Thank you.
Thank you. Andy Scher, Autism Speaks, member of the forum. I have a question for Menelik. You mentioned that in your evaluation that a very low percentage of the children show pro-social behavior. Do you mind elaborating on that a little bit and the potential implications?
Thank you. My question first is to say I'm glad to see the cow project and the milk, because the milk supposed to be easy accessible, but in a lot of the countries in Africa it's a luxury product that it should not be. As you introduced the cow in the school, what services, who services the cows? How is it linked with the veterinary? And what is the smell, the things conferred in the school? Because I think you need first a different space, a lot of space to accommodate the cows, but you need a lot of services to the cows, and the environment with the cows, and the treatment, etc. How do you work with that part of the cow's product?
Thank you. Abarra raised a very pertinent question with regard to disciplining children and the cultural perspective of it. It's true that children are seen culturally as just growing objects, not as human beings with feelings and thoughts and needs and wishes. This has been a big problem culturally, actually, but thanks to continuous media education, at least in urban areas, this appears to be changing. It's not only that children do not know. There is a saying that a child who is not beaten will be, more or less. That is the saying as it goes. So in some places, this was a norm actually where I grew up. Unless a child gets a dosage of beating or whipping regularly, then the parents would think that the child will go bad behaviorally when he grows up. So whether you do something wrong or not, maybe every Sunday morning when dad is home, you will get your regular dosage of beatings. This used to be the norm, so that's very true. And currently, this has not died, actually, even amongst teachers. I can tell you my own experience. In some schools, we have an agreement that each school should have a policy of not physically disciplining children. This is actually accepted by the Ministry of Education here. A teacher cannot physically discipline a student. But in many schools, when you go there, you find teachers, empty-handed, but if you go around the corner and hide and look from a distance, you will see them, pulling it out of their gown, They had hidden sticks with them. So it is still pertaining. People seem to be opting for a fast, impact, and physical punishment does produce fast impact, You slap him, he stops whatever he's doing. But nobody is realizing, the long-term consequence of such a thing. So it all falls upon us, to educate society and to gradually change them. I recently went to a Catholic-sponsored church, and I met with resistance from the school director when we raised this issue of disciplining. And he said, Menelik, first you have to go and teach the parents. Parents are coming and blaming me for not physically disciplining their children. What do you expect us to do? This was the reaction from the school. So this is a very true thing that you mentioned, and that's what we work on. One of the 11 parent training manuals that we provided the 3 ministries is exactly on this, on how to positively discipline children. And the other question I was asked was about the impact, about the lack of pro-social behavior in the children. Again, that is true. And I think it has to do with our child-rearing behavior. And I think Abara's remark also impinges on this. Now, if children do not know, if children cannot have any rational action or any rational thoughts, no parent wants us to train their children how to behave, how to modify. They're just expected to do what they have to do. And mostly, parents who teach their children get away from their children or keep to yourself, such things. So, children need to be trained about pro-social behavior, and this is one of the things that we train. Thank you.
Thank you. I like the cow project too. I started to interpret everything into cows, like how much money I'm paying for my office rent. Like I found out I'm paying 10 cows a year, and I thought that was very expensive. It just gives me a better understanding of money since then, that how many cows a year I am paying for everything. From my understanding, your question is, how is the dairy managed at the school level? So the design is to be very highly decentralized, very localized, very school-focused. In one school community, children in that school, and community in that school area. So there is a committee that includes parents, teachers, school administration, and also some people from the government education administration also. So these are the people who are overseer of the dairy in one particular school, but there are vet doctors, full-time workers, employees, including 6 other people working in one dairy. So these are full-time workers in one dairy, and the school oversees the whole program. Reports are sent from the dairy to the school and then to us, like copied to different even government agencies who are directly monitoring the schools. So this is how it's managed. In the meantime, the skill transfer, for instance, vet doctors, we found out they were the least paid professionals in our job market. I think the reason is because we do not have a lot of dairy farms in Ethiopia. But now, we are even creating employment for vet doctors. Almost this profession was becoming unpopular because they couldn't find jobs. So one of the challenges as we expand was finding highly productive cows, like because we don't have any breeding companies here. So that's even creating another field of business for the private sector to start breeding companies, to start milk processing companies. because we're going to be having plenty of milk produced in one community. For instance, if we have 10 schools with dairy farms, then we will need a processing plant somewhere in the middle. Otherwise, they don't know what to do with the milk, the extra milk. Some people argued this is owned, the dairies are owned by schools, so this discourages small holder farmers who want to start dairy. But we're not there yet. That's our argument. We're not there yet. We see these children who are raised in these schools becoming dairy owners in the future. So after maybe 20 years down the road, we may not need, or 25, 30 years down the road, we may not need school dairy farms. But now we do, to cut the vicious cycle. Thank you.